syncope in seated position. That is very important, or supine position. Syncope while driving. You have history of palpitations before syncope. These are all red flags where you need to look and rule out cardiac cause for syncope. And very important is having syncope during exercise. So if the child is exercising, running, and at that time has a syncope, you need to think in terms of arrhythmias. While vasovagal syncope will be common after the child has stopped exercising and then has an episode of syncope. So treatment of vasovagal syncope is very simple. You give plenty of fluids. You can add extra salt and sugar in it. Avoid starving for long duration. Ask the child to have small frequent meals. As I said, episodes are common while standing in assembly. So whenever they are standing, ask them to bend the knees intermittently. In the morning, it is very common to have syncope just while waking up from the bed. So get up slowly from the bed, stretch your muscles before getting off. Some kids pass urine and have a syncopal event in the washroom. So always ask them to have a breakfast before shower. Slowly regulate the temperature of the shower. And whenever they are giddy, ask them to lie down and passively raise their leg rather than falling down. By doing this, most of the patients with vasovagal syncope episodes are controlled. Very few of them require medication. Now, coming from vasovagal syncope to this episode in a 9-year-old child, where child had syncopal event while playing in the school. Child examined normally, had normal first and second heart sound. An adult cardiologist was shown and he did a normal echocardiogram. And in his opinion, everything is fine, nothing needs to be done. Child had one more episode at the pediatrician, again sent for opinion to a pediatric cardiologist. And I said most important investigation was missed in the first time, that is the ECG. So if you look at the ECG, the QT interval is prolonged. It is around close to 0.7 milliseconds. So that is also around 700 milliseconds. So the child probably has a long QT interval with source of BTAC in between. Then after this, we dug into the history, and there was a history of sudden death in the maternal uncle. So this is probably a congenital long QT syndrome. Child was started on beta blockers, the episode reduced, child is following up now and doesn't have any episodes further. So takeaway is that most important in case of syncope is history. If there are any red flags which I had mentioned, then you should think in terms of cardiac syncope. If child is clinically normal, no signs of cardiac failure, no murmur, normal first and second heart sound, then that usually rules out structural heart problems. So in those cases, it's most important to have an ECG, as abnormal as arrhythmias could be one of the common cause in these patients. And always pay attention to the red flag before labeling any episode as vasovagal syncope. And coming to another OPD problem very commonly seen is the children complaining of chest pain. So you have an 8-year-old boy complain of chest pain on and off for 2 weeks. There are no aggravating or relieving factors. Pain is lasting only for a few seconds to minutes and self-resolving. No associated sweating, change in color. No family history of sudden death or death in early age group. Child is examining normally. There's nothing clinically, no signs at all. So this is the ECG, which was completely normal, echo, which is normal. So this is a very common scenario where chest pain, child comes with chest pain in the OPD. By and large, chest pain in pediatric age group is non-cardiac. So it is not important to investigate always. But if you have recurrent episodes, document a normal ECG, document a normal structural heart. In the heart, the echocardiogram, just look whether the coronaries have been looked at, the valves are normal, there's no mitral valve prolapse, there's no pulmonary hypertension, and also function is normal. Most common cause in pediatric, the chest pain is due to musculoskeletal cause or gastritis. Most of them do not require any further investigation unless there is a history of some cardiac surgery in the past, history of recurrent chest pain, history of Kawasaki disease in the past, or familial dyslipidemia, or there is typical congenital symptom which is very rare to happen in pediatric age group. So I'll end with my take-home message from this is look for if to pick up congenital heart disease, acyanotic heart disease, look for symptoms of slow weight gain, fast breathing at rest, suck cycles, repeated lower respiratory tract infection. If the symptoms are continuously present, then it is more likely to be cardiac. If they are episodic, more likely to be respiratory. Always use a saturation probe to look for low saturation that is less than 90%. Cyanosis will be visible when the saturation is less than 85%. Any murmur that you hear on more than one occasion should be investigated and evaluated. If the child is symptomatic and has a murmur, then don't wait for second examination. Just send for evaluation. Syncope is more of a clinical diagnosis, and most important investigation is ECG, provided the sign has no signs. And chest pain in pediatric age group, by and large, non-cardiac in origin. And whenever in doubt, only then you investigate. Thank you for your patient listening. If you have any questions, please put up in the chat box. I'll be happy to answer them.
Good afternoon, everybody. So today, I guess somebody has the speaker on. Can we, if you can mute yourself, please. Thank you so much. So, good afternoon. I'm Dr. Priya Pradhan, and I work in SRCC as a consultant in pediatric cardiology. And today I'm going to speak about advanced diagnostic tools in pediatric cardiology. So, just now we spoke about the echocardiogram, but that is not it. So, cardiologists also have to perform many other tests before we take the patient for any surgery or interventions. Many patients require a variety of tests. So this, though it's not tea time, it's time for TEE. That's echocardiogram. So what is a translucid echocardiogram? Basically, it's a test in which we pass on a ultrasound tipped probe through the mouth of the patient. And as you see in the diagram in the left side, this probe goes from the mouth through the nasopharynx into the esophagus, and the heart is just anterior to the probe. The movements of the probe, you can turn the probe clockwise, anti-clockwise. You can make it anti-flex, like you can turn it anteriorly, take it posteriorly. And in this way, you can have different angles and different images of the heart. So now, what is the advantage of this test over the other traditional echocardiogram? So here the images are really very clear. So you can see if there are small infective endocarditis foci, you can see other structures like pulmonary veins or coronaries very well. Sometimes the surgeon also wants for the VSD rootability. So what is the rootability? Is basically you have to communicate the left ventricle to the aorta. So in cases of large VSDs or if there are malposed great arteries, then the surgeon needs to see exactly what route he has to take when he places his patch. And hence, this can be seen very well in the transesophageal echocardiogram. Also, when we do device closures, we take a look at the defect in the transesophageal echocardiogram. So here this patient had multiple holes, which is the interatrial septal defect. And we needed to see that. We were not able to see that through the echo, so we had to do a TOE. Perioperatively, we see whether the adequacy of surgery, surgical closure is fine, or even before the surgery, if the surgeon wants to see any more details. Time required depends. It usually requires 15 to 20 minutes for the procedure. Patients are sedated. For the procedure, short IV sedation is required. And this procedure can also be taken place in a daycare setup. So this is just some pictures for you to get an idea about how in the perioperative period we do the transesophageal echocardiogram. So this is in the operation theater, the probe is through the mouth of the patient, the surgeon is looking from the other side, and we are looking at the pictures on the screen. There's another imaging technique, it's the echocardiogram, which we call as epicardial echo, in which we place the probe directly over the heart of the child. So this again is done when sometimes the probe size is bigger for the child. So very tiny babies, the probe won't go through the esophagus, it's too big for the baby. So in those cases, we perform a epicardial echocardiogram, especially in patients with TAPVC, TGA. So these are all very tiny babies requiring surgeries in the first week of their life. So next we go to the CT angiogram. CT angiogram is basically a plain CT is not very useful for us in cardiology because we have to see more of the structural anatomy, which is best seen with angiography. What is angiography? Is basically you give an IV line to the child and you pass some contrast through the IV line and we see the structures of the heart. So again, in this way, structural analysis can be done much better in a CT scan than a traditional echocardiogram. So extracardiac structures like branch pulmonary arteries, major aortopulmonary collaterals. If there is any signs of airway compression, CT gives beautiful imaging. What is the site of the compression? In case of rings, slings, lung pathologies can be very well seen. Very small structures like coronary arteries, pulmonary veins. These are best seen in the CT scan. And if any patient has poor transthoracic windows, or if there is some heterotaxies like dextrocardia, mesocardia, in which the transthoracic windows are not very good, in those cases, we need a CT scan. Requires around 30 minutes of time. Patient may or may not need sedation. Even in the newborns, we can just wrap and feed them and they can sleep through the procedure. Or else even in bigger children, we can explain them the procedure and they do quite well. Serum creatinine test is required prior to the contrast injection. But here the only drawback is that the radiation dose is quite significant. So you cannot keep on having repeated CT angiograms for patients. Also, there's the thing about contrast allergy, which we have to take care of. If the neonate has, especially neonates or any child who has very high heart rates, the imaging may be a little suboptimal. And of course, it cannot be done in pregnancy or children undergoing radiotherapy or the children who have heightened risk of cancer. So here is an image wherein this is a patient. So if you can see on the image B, you can see the aorta and the pulmonary artery. So aorta has to give rise to the coronary artery. So if you can see, the coronary artery is coming from the aorta, but the left coronary artery is absent. So only one coronary artery is coming out from here. So where is it coming from? It's coming from the pulmonary artery. So this is a case of Al-Kappa, that's the anomalous origin of the left coronary artery from the pulmonary artery. That was very well diagnosed because of the CT scan imaging. The most regular cases which actually go for CT scan is the patients who have tetralogy of Fallot. In the first image, you can see that there's a VT shunt. So before you go for complete repair, we need to see the exact size of the branch pulmonary arteries.
Okay.
kinking of the pulmonary arteries. So all these very detailed information can be only obtained from CT, and you cannot see it in a normal transthoracic or transesophageal echocardiogram. The next image below is a patient with coaptation. So even for interventions, before we have to decide about the stent size, CT is very important, and it gives us very great imaging and information about what size of stent we need to choose. The other image here is a TAPVC. So we will discuss it more in the details. It's basically all the pulmonary veins are anomalously draining through the innominate vein. So this structure which is going up is the innominate vein, and which is coming down on the right hand side, which is basically the left hand side of the screen, is the right superior vena cava. So it's a figure of 8 which we see on X-ray, is seen on the CT here. This is a very beautiful 3D reconstruction image of a patient who is just admitted in the ward and had his CT just yesterday. So this is basically an arch anomaly. If you can see, the aortic arch comes from the right side, and then from behind it goes to the left side. So it's an arch anomaly. We call it as a circumflex aorta. So CT, of course, prior to surgery, many of the patients undergo CT imaging to get more information about the anatomy. Next is MRI indications. So in cardiology, we don't do MRIs very often, but even then they have a very specific indication and a very, very useful in certain set of patients. So for functional assessment, if you need to know exactly what is the function of the ventricular chambers, especially when you have single ventricle conditions or cardiomyopathies, to monitor them. Volume assessment you can do for left ventricular or right ventricular volume. So in case of tetralogy of Fallot patients, when they have a transannular patch, that means the valve has been cut open during the first surgery. The valve has leakages, which may lead to volume overload of the right ventricle. And then as they grow up, the right ventricular volume increases and we need to replace the pulmonary valve. So in those cases, when to actually the timing of the procedure can be decided upon serial MRI scans. Similar with aortic valve replacement. So the timing of surgeries we can decide from the MRI. Sometimes even the etiology of cardiomyopathies. If you have decreased function of the myocardium, you can, if you do an MRI, you can see there is if there's fibrosis or the storage disorders, you can see the muscle looks different, and that is how you can diagnose the pathology. So mostly again requires sedation because it's a long procedure as opposed to CT, which can be also performed without sedation. Here it requires around 2 hours. There's no radiation hazard, but the machine is quite noisy and it becomes quite claustrophobic for patients. And then there's another new modality which we use is the CMR, wherein actually it's like an angiography through the MRI. And here we can have very beautiful pictures. We can also use this when we are doing cardiac catheterization. So here your volume assessment, pressure assessment can be done in this methodology. So I'm going to show you a little bit of pictures. So what actually happens in an MRI, if you see this, the 2 dots. So at different cardiac phases of the cardiac cycle, we are studying about the volumes of the left ventricle here, and we are getting the ejection fraction. So systolic volume and diastolic volume, if we know, then we can get the exact ejection fraction of the ventricle. This is another patient whose MRI we did, because if you can see, this right ventricular outflow tract has an aneurysm here. So this patient actually we wanted to study for pulmonary valve replacement, but we saw that there was this conduit on the third picture, which I'm playing right now. You can see a conduit which is quite lucent here, and there's an aneurysm just below the conduit, which is causing a RV volume overload. So helps in planning of procedures. Next testing, next advanced test is genetic testing. See, we all know that cardiac defects, 20% of them, as high as 20%, are associated with some kind of other abnormalities. They are syndromic associations with cardiac defects. So many patients also may not be syndromic, but they may have genetic associations. And hence, it's very important for the overall outcome of the baby to know these genetic associations. So it basically helps prediction and prognostication for that baby. And then it also helps in give advising for the future pregnancies. So if what conditions they are, we can actually give them the incidence of recurrence in the next pregnancy and the tests that they can do during the fetal from the amniocentesis to avoid those kind of problems in the subsequent pregnancies. So whole exome sequencing is commonly advised very in case we are not suspecting any particular problem. Otherwise we can do fish and karyotype, which are quite specific tests. So we order them very routinely when we see certain type of heart diseases, or if there is a family history, or if there is a syndromic association. And the sample can be either amniotic fluid, even the buccal mucosa, saliva, blood. But just the drawback is that the test takes time. So it needs at least 2 to 3 weeks for the results to come up. Another very important test is the fetal echo. So fetal echo is when we scan the heart of the child when he's in the womb. And the mother, we scan the mother, and this is the indications. So if not everybody requires a fetal echo, but if the mother has a family history of congenital heart disease or metabolic disorders like diabetes, if she's exposed to teratogens or is exposed to certain medications like ibuprofen, salicylic acid, certain kind of infections make you more prone for heart diseases like rubella. Autoimmune diseases like SLE may predispose the baby to have a congenital heart block or other lesions. And then there are family inherited disorders like the Marfan's, Noonan's, Erisparkil one. In vitro fertilization is another indication because we see cardiac defects more common in these kind of pregnancies. In the fetal indication, basically, when they are doing a ultrasound scan for the mother, if they notice that the radiologist notice any abnormal cardiac screening, any abnormal heart or rate or rhythm in the baby, or if they have found any fetal chromosomal anomaly, extra cardiac anomalies like spina bifida, because again, there are associations with these kind of anomalies with cardiac defects. Non-linear high drops, if there's increased translucency, as we see in the Down syndrome cases, in case of twins. So best timing is after the anomaly scan, that is the second trimester. Though we can also do an echo in the first trimester, we can do a trans vaginal echo or a trans abdominal echo, but the cardiac details may not be elicited well. But by the second trimester is a good time, and we can detect most of the anomalies which are quite grievous anomalies. So simple defects like an ASDC, these are the defects which will be present in a normal fetus for the fetal circulation, like a PD and ASD. And other small defects can be missed, but major defects like transposition of great arteries, TAPVCs, which are going to be life-threatening for the baby and which will require the baby to be the birthing to happen at a particular place, like a center where all the facilities are available for the baby, a good neonatal care is available, and cardiologists are available at birth, is very, very essential. Since certain kind of duct dependent lesions, if the PDA closes, then that can be fetal, can lead to fetal morbidity or mortality. So this procedure takes around 30 minutes to 2 hours. There is no prerequisites like fasting. In fact, a well-fed mother is better because the baby will be quiet and we get better imaging. So this is how we do the fetal echo. We scan the baby's heart in different planes. And like an example, so there are some certain standard views. Oh, so it's not playing very well. This, which a radiologist performs the fetal echo in, but for cardiologists, we just do it in our own way. So we have to see the 4-chamber view, the 3-vessel view, the 3-vessel trachea views, the arch views, the ductal arch, fetal arch, and all these structures. Now, in this case, there's an abnormal echo and a normal echo. If you all can notice, so this is, I'm not sure. So this is basically the image A has a defect in the interventricular septum. I'm going to play it again. So is my marker seen? Yes. So this is the defect in the interventricular septum. So this is a patient with the ventricular septal defect. And in this case, in the image B, you can see that it is normal. There is no defect there. This is how we diagnose fetal conditions in fetus. by a fetal echo. Next test I'm going to talk about is Holter monitoring. Basically, it's an ECG test which is done over 24 to 48 to 72 hours. So where do we require this test? This test is required when we suspect rhythm abnormalities. So if a patient has palpitations, or as Kshitij said, syncope, some with palpitations, or any kind of cardiac problems with palpitations, we always want to get an Holter done for this child. So this can be done for patients with heart blocks to see exactly what is the timing for intervention. So not all heart blocks require pacemakers. Only if they fit into certain criteria in a Holter, we advise them to do a pacemaker installation. So this is a typical Holter report wherein we see all the beats and how many supraventricular beats, what was the average heart rate, what was the minimum heart rate, all that is given. And this is how we screen the whole 24 hours ECG to see for any abnormal rhythm. So here in the right hand side picture, we have got this abnormal rhythm. So this is a ventricular, the abnormal ventricular tachycardia here for the patient, and we also give a diary to the patient so that we can correlate. So during this time, whether the patient was also having some symptoms. There's another thing called as an event monitor. So Holter monitor, when you have if the symptoms don't occur during the Holter monitoring, then we won't get any kind of diagnosis. So for those cases, we have this event monitor. Again, it's a very modern device wherein which we can stick it to the chest wall when the patient starts getting symptoms, and it starts recording the ECG during that time. And that helps us to diagnose the problems and manage accordingly. So there are a lot of abnormal pathways which require electrophysiological studies or even ablation of those abnormal pathways. All these can be diagnosed, if not on the Holter, then on the event monitor. So on the next test, this is just a picture to give you a hint about the next test which I'm going to talk about. So it's basically the stress test. The lady is now going to be subjected to stress. So this is how we do a stress test. In our hospital, we don't do the spirometry. We just have ECG leads connected to the patient along with the blood pressure monitoring and even saturation monitoring, and we make them run on a treadmill. It can also be done on a bicycle in infants who cannot run. So above 5 years, most of the children can very well run on a treadmill, but below that, if we need. So basically this test is done to see what happens at the peak of cardiac activity. When you subject the heart to its maximal activity, is it tolerating it well? Is the blood pressure response, the heart rate response, the saturation response appropriate or not? So that is what is tested in the stress test. Can be done in children as well with drugs like dobutamine, which increase the cardiac contractility as well as the heart rate. So here, this test usually routinely performed in patients with single ventricle for prognostication. Again, conditions like pulmonary valve replacement or coronary abnormalities can be diagnosed. Even coronary anomalies basically can be diagnosed with this problem. So this test, if chat box open, can anybody tell me what this test is? Okay. So this test, you can see here, there's a table and it has been tilted.
Tilt table test.
Perfect, ma'am. So Dr. Hemali says it's tilt table test, it's perfect. So this test is also performed in our hospital, and we do it for patients, especially with who complain of syncope. So what is better now? Next question, is a positive tilt test better or a negative tilt test better? Anybody? So the answer lies in the next line. Basically, what we are going to try to do in the tilt test is we want to
postural fall, madam. Postural hypotension patient and patients like sick sinus syndrome, like.
Sure. So on the right hand column, we have given how we report a tilt table test. So basically, we want to see the blood pressure response, the heart rate response, and the heart rhythm response on passive standing. So what happens in different conditions, we can actually diagnose if we can mimic the syncope, or if we have abnormal changes in the BP, heart rate or rhythm, then we can actually predict what would be the cause of the syncope. And that's how, like, as you said, the vasovagal syncope or POTS, that is the paradoxical or orthostatic hypotension, or you have these kind of cardioinhibitory, vasodepressor, or mixed kind of responses. And then our treatment strategy changes with them, whether we give a lot of water and salts in case of the POTS syndrome or the vasodepressor kinds. And we also can sometimes give medications to the patients who have a very abnormal responses at even in very short time. So this test usually takes 90 minutes because we want to mimic we want to cause that much of prolonged standing so that we can actually mimic a syncope if possible. So it's always good to have responses so that we know whether actually this syncope was caused because of the cardiac problem or if it was only a CNS problem. So syncope can also be caused by CNS. Like when we for that we then refer the patient for the EEG. So this is the next test is the cardiac catheterization test. Just because this was interesting, I put up a slide. This is basically Werner Fossman, and he did the first cardiac catheterization himself. So during his tea break, he just passed his urinary catheter through his cubital fossa, and if you see on the right hand side, you can see a line. So this is the catheter which is going right into his heart. So he found out that you actually can measure the pressures, or you can go into the heart and measure the pressures there, and that's how cardiac catheterization began. And with Andrik Frederick, who again then did a lot of techniques to measure cardiac output, both of them together then won the Nobel Prize. So what are the indications for cardiac catheterization? It's done for hemodynamic assessment. That means how are the pressures in various chambers and what kind of output is there in the lungs, what is the cardiac output, systemic cardiac output, what are the shunts, so we can quantify the right to left shunt, left to right shunt. We also do morphological assessment, like if there are abnormal vessels in the heart. This test for diagnosis takes around 1 to 2 hours, can be done in sedation or general anesthesia. So this is how in the patient of VSD, we need these calculations to see whether they are operable or not. So we looked at a lot of tests. We asked, are we really spoiled for choice? So no, it's actually, there's no spoil for choice here because every indication for each test is very, very unique. So not one patient may require all the tests, but he may require one test which is very important before the treatment or intervention or surgery is offered. And that's how, as we have so many tests before diagnosis, we also need so many people. So it's not only a cardiologist or a cardiac surgeon who is important in the outcome, but basically a very huge team is required with a lot of technicians and other support staff, anesthetists, intensivist staff, along with all the other physicians and surgeons. So this is our team, and thank you from all of us. And we are open for questions if you have anything, even now or even after this talk. We will have like a panel discussion. So all of us are here. There are intensivists here, this cardiac surgeon and cardiologists. So even in the end, we can have a little bit of panel discussion and take up your questions at that time. The next speaker, I would like to invite Dr. Sen with his talk.
Hi, good afternoon. My name is Supratim Sen. I'm a senior consultant in pediatric cardiology. I hope you can hear me. Please let me know if anyone is having trouble with the Okay, so we'll be discussing interventions in pediatric cardiology. So in the present era, a lot of structural interventions can be done in the cath lab by minimally invasive techniques. And these cath lab procedures are as effective as surgery with quicker recovery in these specific situations. So I'll just show you a few cases of interesting, challenging work that we have done. So this is quite a common case scenario for us. This was a 10-day-old neonate who was discharged from nursery on day 4 and then comes back on day 10 to the casualty with refusal to feed and respiratory distress. And this was the ER assessment. You can see the baby had tachycardia. The femorals were not palpable. And there was a soft ejection murmur on auscultation. The venous blood gas showed severe metabolic acidosis. So any idea what is the diagnosis here? You can unmute yourselves and shout out. So this is a severe coarctation of aorta with LV dysfunction. And on echo, this is what it looks like. So you can see this is the arch of the aorta, and there is a tight narrowing of the coarctation seen here when we put the color box. The reason coarctation presents after a few days and not immediately at birth is because, as you know, that babies are born with a PDA, and only once this PDA constricts will the flow of the lower body get affected, as you can see on this schematic diagram, and which is why the patients usually present at the end of the first week or the beginning of the second week of life. So because this child had left ventricular dysfunction, we put this child to cath lab for a balloon angioplasty. You can see on the left that there was a tight narrowing. And on the right, you can see that we are dilating this with a balloon, which opens up the coarctation. I would like to stress upon here that we only do a balloon angioplasty in neonatal cohort if there is left ventricular dysfunction. If the baby comes to us early with a normal function, then we always send these patients for surgery. The reason being that the recurrence rates are significantly higher with balloon angioplasty compared to a surgical repair of cohort. So once you relieve this obstruction, the babies have quite a dramatic recovery. This particular patient had a normal LV function within 24 hours, and we could discharge home after about 3 days. So important learning points from this case is that in an acyanotic baby with an acute deterioration, it's not always sepsis. You should think of duct-dependent conditions. And metabolic acidosis with high lactates indicate an inadequate systemic circulation, and you should think of causes other than sepsis in this. I would like to also reiterate here that it is good to always palpate the femorals a second time before discharging a baby from nursery. I know that all pediatricians routinely palpate femorals at birth, but because the PDA is open at birth, you might miss a coarctation when the PDA constricts if you don't check a second time. Now, the second case was a 14-day-old baby weighing 3.1 kilograms, and this baby was cynosed but had a quiet respiration. SATs were only 60%. There was no obvious murmur on auscultation, but an echo was warranted because you have cyanosis with quiet respiration. And the diagnosis here turned out to be VSD with pulmonary atresia. So as you know, in pulmonary atresia, the communication between the right ventricle and the pulmonary artery is absent. And so the deoxygenated blood will mix at the VSD level, go into the aorta, and then through the PDA, we have some flow into the lungs. So the initial treatment of these patients is we start them on a prostaglandin infusion, and then we do a palliation such as a PDA stenting or a BT shunt. And at about 1 year of age, we will do a complete repair where the surgeons will close the VSD and connect the right ventricle to the pulmonary artery with a tube or a conduit. So all conditions where there is pulmonary atresia have a duct-dependent circulation, which means that they are supplied only by the PDA. And all of them hence need some sort of a palliation where we can re-establish the connection, re-establish the pulmonary blood flow, which usually is with a PDA stent in our case. So what we do at SRCC is we have regularized the hybrid PDA stenting with a carotid cut down. And you can see here that the baby is turned with the head towards the foot end of the table. And the first step is the surgeons give us the carotid cut down. So this is the neck. You can see it's a very small area which is exposed. We do a small incision, and then the common carotid artery is entered with this small sheath. And once the surgeons give us that access, we have a direct view into the PDA. So you can see the PDA just comes off the undersurface of the aortic arch here. These are the pulmonary arteries. And so just by, sorry, I'll just go back. Just by pointing into the PDA, we can cross it with a wire. And once the wire is in good position, we push in a stent. In this case, this was a coronary stent. And then we do a few check angiograms to check that we have covered both ends of the PDA. And once we are happy with the position, we can inflate the balloon and the stent is deployed. So this procedure is known as PDA stenting. And we take out the balloon first, leaving the wire in, and then the wire comes out. And that's the final result. So you can see the stent in position with good flow into the pulmonary arteries. So we started doing the hybrid approach of this since 2020. And this is also with the flip technique, which I showed you. And so far, we have done 37 such patients. The median age at intervention is around 20 days, mean weight of around 3 kgs. And it takes about 20 minutes of fluoroscopy time, and the whole procedure takes about 1 hour. The hospital stay is around 11 days. Median follow-up we have for these patients is about 8 to 9 months. And we've not had any complications due to this vascular access. Since the time of the last follow-up, 25 of these 37 patients have undergone their corrective surgeries also. So we had one early mortality due to sepsis, and one of these cohort had late mortality due to COVID 7 months after the procedure. So this was our initial experience with hybrid stenting. This was the first 11 patients, and since then we have this has become a very routine and standard procedure for us. The next patient, similar newborn baby, 3 weeks old, transferred from another hospital with cyanosis. You can see SATs were 74%. And there was a harsh systolic murmur in this child. So we didn't have a diagnosis at the time of the transfer. But when we did the echo, this baby had a pulmonary atresia with an intact ventricular septum, with a good sized right ventricle and a moderate PDA. So this is what this condition looks like. You can see here that the pulmonary valve plate here is the valve doesn't go through, so there is no flow across the pulmonary valve. And basically the baby is surviving again on a PDA. But because this is a discrete absence of the pulmonary valve known as pulmonary atresia, we can perforate this. So we are now in the right ventricle. You can see there is this blind ending pulmonary valve plate. So we aim our wire to this plate and we perforate the plate. This is one of the high-risk procedures in neonatal pediatric cardiac interventions, because instead of perforating into the pulmonary artery, if you perforate out of the heart, you'll have massive hemorrhage and tamponade. But if you do it carefully, you can get a very nice result. So you can see we have gone through the pulmonary valve here. We have snared it out of the other side. And once you have that pathway, you can put in a balloon. So we are gradually increasing the size of this pulmonary valve. And we are putting in bigger balloons and making it the antegrade flow better. And this is the final result with very decent antegrade flow. So this patient was then shifted back to the NICU, and we observed for the next 7 days, waited for the PDA to close completely. And once we were happy that the saturations were adequate, this patient was discharged. And this child is now doing well at 3 years of age, has not required a second procedure after that neonatal procedure. The next case, again, highlights the teamwork approach which is needed in pediatric cardiac care. So this was a 7.5-year-old girl. weighing 16 kilograms. And you can see from the blood pressure difference that the upper limb blood pressure is slightly higher than the lower limb blood pressure. And the child also had a loud P2 and an ejection systolic and an early diastolic murmur. So the diagnosis here was a large PDA with a moderate long segment coarctation of aorta. So as you know, generally in pediatric cardiology, if you just have a PDA device closure is our routine procedure of choice. But if you put a device when there's a coarctation, you're actually going to worsen the coarctation. So device closure was not a great option here. We're putting a balloon here through the PDA to see that this child is actually operable because they presented quite late. But we discussed this option would be to do a covered stent, which would take care of the coarctation and also occlude the PDA at the same time. The only challenge then becomes that this was a child weighing only 16 kilograms, and we would need a very large arterial sheath to put in this big stent. So what we decided on was a hybrid coarctation stenting. And here the surgeons gave us a vascular access similar to an appendicectomy incision. And you can see that the vessel size is much bigger there than the femoral artery. So this is the common iliac artery which has been exposed. And then the procedure becomes much easier for us. We have put in this very big sheath and we are checking angiograms to see the narrowing of the aorta there. And this is the stent. So this is in two planes. This is lateral and this is anterior-posterior. And we are slowly inflating the stent. And then we are doing angiograms to check that we have completely occluded the PDA. You can see there is no filling of the PDA or the pulmonary artery. And the aorta also has become larger in size than what we began with. This is known as a 3D rotational angiogram, where we are checking a 180 degrees view to see that there is no leak or dissection anywhere after the stenting. So hybrid interventions help us overcome size limitations of the conventional percutaneous access, and it is also safer to maintain vascular patency. The next case is a rare but very interesting case. This was a 7-year-old boy, again, around 16 months, and his only complaint was severe cyanosis, saturations of only 56%. The child had normal heart sounds. The baseline echo done outside was also normal, apart from a dilated right pulmonary artery. So whenever we have this type of a presentation, we do a contrast echo, where we take an IV access and we inject agitated saline into the vein. And you can see here that the contrast echo was strongly positive. And what that means is that in a normal heart, the right ventricle ejects into the pulmonary arteries, and then there is a mechanical filtration at the pulmonary capillary bed. So any air bubbles in the right ventricle will not actually come to the left atrium via the pulmonary veins. But if you have a short circuit, which is known as a pulmonary AV malformation, then you will bypass the pulmonary capillary bed, and air bubbles from the right ventricle will come into the left side. So that's what was happening in this case, which is why the bubble contrast was positive. And this child had a clinical diagnosis of pulmonary arteriovenous malformation. This was the X-ray, so there was a suspicion of the pulmonary AVM even on the X-ray. We did a CT scan which confirmed it. You can see this huge right pulmonary artery to left atrium AVM. That is the RP on top, left atrium at the bottom, and there is the pulmonary AVM. So we took this child to the cath lab. This is an injection into the right pulmonary artery. Catheter is through the AVM and then into the left atrium, left ventricle. And once we have our wire, we have pulled the wire out of the aorta and out of the femoral artery to form a arteriovenous loop. And over the wire, then we put in this big sheath. So this sheath is going from the IVC, RA, RV, right pulmonary artery into the pulmonary AVM and then into the left atrium. So this is our delivery sheath through which we are now putting in this big device. So we are slowly adjusting the device so that it only obstructs the AVM and doesn't obstruct the surrounding structures. And we are also doing a transesophageal echo here while we are aligning the device. So as you can see, as we push out this device, it reforms to take its original shape. We do angiograms to check that we have got the device in the correct position. And finally, we unscrew the cable and the device is released. So you'll see that this connecting cable will disconnect and the device sits there. So this is the final result. And this leads to an immediate improvement in the saturations. This child was observed in PICU overnight, discharged after 2 days, and came to us for follow-up a couple of times after that. This was 5 years ago. The child is doing well and is absolutely normal. So pulmonary arteriovenous malformations are a very rare cause of cyanosis. We should suspect them if there's nothing obvious on the baseline X-ray or the echo. And this is something which needs to be treated to improve the saturations. I'll also show you a couple of cases of double devices, which just means that the child had 2 left to right shunts in the same patient, and we treated both of them in the same sitting. So the first child was 4 years old, 10 kilograms with a moderate VST and a moderate PDA. So this is the ventricular angiogram. You can see there is a VST there. And that is the aortogram. So there is a PDA which is connecting to the pulmonary artery. So first we cross the VST. We have gone through the VST into the right ventricle and into the pulmonary artery. We then snared this wire out from the other side. So we have taken a venous catheter. We will catch hold of this wire and snare it out to again form an arteriovenous loop. And once you have an arteriovenous loop, then you can put in this big sheath. So this is going from the right ventricle into the VST, LV, and aorta. And then through this sheath, we will put in our device. This is the VSD device. So the device is now being deployed. So there is the first disc, which is on the LV side of the VSD, and the second disc, which is on the RV side. And then on this angiogram, you can see that the VSD device is nicely in position and there is no residual VSD flow. But before releasing this device, we will then do, we will close the PDA also. So again, we have gone from the pulmonary artery across the PDA to the descending aorta. We have put a sheath over that. Then we put in the PDA device. So when we deploy the PDA device, the first disc is on the aortic end of the PDA, and then this is the tail of the device, which is the pulmonary side. So here we are doing an angiogram to check that the PDA device is in good position. We have released the PDA device in this middle cine flow, and then the last step is releasing the VSD device. So transcatheter interventions versus open heart surgery have definite advantages. These procedures have a quicker recovery. There is less pain. They are discharged quicker, and there is no surgical scar. And we don't have to expose or subject the patient to cardiopulmonary bypass. But there are limitations. Not all congenital heart defects can be treated with transcatheter interventions. Surgery is the only option in many of these patients. There are age and weight limitations. And also, we don't want to put in very large delivery sheets into this patient who is small, because then you might damage the vessel. But if possible, we want to avoid this type of a morbidity, because you have a very quick recovery with a transcatheter intervention, as in this child who is 1 day post VSD closure. So is there a minimum age or weight for cath lab interventions? No, for balloon angioplasty. We have done procedures such as coarctation balloon and balloon pulmonary valvotomy, even in children less than 1 kilogram of weight. For PDA devices, now we also have a special device which can be used in preterm infants, which is FDA approved. For VSD devices, we generally want the patient to be 5 to 6 kilograms of weight, And for ASD, that's around 8 to 10 kgs of weight. For surgery, there is no minimum age or weight limitations. We can even do a 800 gram or 1 kg baby surgery if it is really indicated. I'll end with this routine case of a PDA device in our cath lab, just to show you what exactly happens in a device closure. So we have a cardiologist, a nurse, a anesthetist, and a catheter who are required for these cases. The first step is the access. So we do a vascular access with a percutor and Eldinger technique. We take an artery and a vein. Nowadays, for smaller babies, we routinely use ultrasound-guided access, which just makes the whole process a lot quicker. So you can see here that we get the needle in, and then we put in the guide wires. Over these wires, then the sheets will go in. So we have one arterial and one venous sheet. In a PDA device, the first step then becomes the angiogram. So as you saw in the case I showed you, you do an aortogram, which looks like this. And this is the aorta, this is the PDA, this pulmonary artery. We then cross the PDA with a wire, and then over that wire, this delivery sheath is going in. You can see we are pushing this sheath over the long guide wire, and we'll watch the fluoroscopy on the X-ray while we do this. So we are going from right atrium, right ventricle, pulmonary artery, and into the descending aorta through the PDA. So this is what the device looks like. It has what is known as a shape memory. So you can slenderize this into the loader, and when you push it out, it will retain its original shape. So we are now flushing the system and pushing this into the delivery sheet. And when we push the device out of the other end, this is called the deployment. You can see that it again reforms in 3 discs of the device. So we pull this into the PDA. We do an angiogram to check that it is in the position we want it to be at. And then, as you saw in the previous cases, we will unscrew this and the cable gets detached from the device. So that's the principle of the catheter interventions we do in pediatric cardiology. I want to stress that prognosis and long-term outcome of most CHDs is very good. And recent advances in technology and increased operator experience means that with these minimally invasive techniques, we are able to treat a large variety of complex CHD in the cath lab. Thank you. If anyone has any questions, you can ask, or you can put it in the chat box. I'll answer your questions.
Good afternoon, everyone. I am Dr. Pradeep Kaushik, cardiac surgeon at SRCC Children's Hospital. Greetings from SRCC. It's a branch of Narayana Health, which has excelled for more than 2 decades in the field of cardiac surgery and all other specialties as well. And SRCC was started in 2017 with 207 beds. We have separate an ICU, pediatric, and cardiac ICU. And all the services are 24/7. this is my brief particulars. I'm associated with Narayana Hospital for last 18 years. And we started the cardiac unit in 2017 along with the inception of the hospital. So I'll just talk to you all about what are the congenital heart disease and what is the surgical timing of intervention. So congenital heart disease are any structural heart defects which are present since birth, in which the acquired defects we are not discussing, which is Kawasaki or rheumatic. And the incidence is about 1 per 100 live births in India. So that takes the number to almost like 2.5 lakh kids are born with congenital heart defect every year. And all over the country, whatever the intervention and surgical centers, we are only treating about 70,000 of the kids. So you can imagine that hardly 1/4 are getting treated, and all these are getting added to the next year pool of the new babies born with congenital heart defect. So the volume of the congenital heart disease is too much in India. And already I think the cardiology colleagues have discussed with the case scenario, but theoretical discussion of acyanotic and cyanotic. So acyanotic, in which the baby has congenital heart defect but does not turn blue. So they can have a shunt lesion, but because the shunting is from the left heart, which is oxygenated blood to the right side, so the defect is there, but because of the shunting of left to right, the babies are not turning blue. Those are called as acyanotic. The examples most common are ASD, VSD, and the PD. If you have obstructive lesion like coarctation, again, the baby will not be blue. And then common example of the cyanotic lesion. Now, if you see the right picture, why the baby becomes cyanotic? Because there is again a shunt lesion, but now the right heart pressure somehow is more, and that's why the shunting of the deoxygenated blood is more into the systemic circulation, and that's why the baby is blue. It can be either the wrong connection of the deoxygenated blood into the systemic side, that also will lead to somebody turning blue. So those are the typical example of cyanotic lesions. And let's discuss about what are the common timing, what time we do the surgery. So this is a 5-year-old child which was just taken to OPD, otherwise no symptoms. And even if you leave the cardiac auscultation, the SATs are good, there's no cardiomegaly, and the echo diagnosis revealed atrial septal defect. So atrial septal defect in asymptomatic child, we operate between 2 to 4 years of age. And all the ASDs are subjected, if possible, for a device closure, in which the hospital stays about 1 to 2 days, and there's no scar. It is done by the cardiology colleagues. Now, if there are not enough margins, then only the patients come for surgical closure. Now, being considered as the simple among all the pediatric cardiac operations, we try to give a minimal scar or a minimal invasive approach for these type of open heart surgery. So we have done it by the right thoracotomy, so the scar is not at all seen, or else we do by mini sternotomy, in which we do not open the whole of the sternum. So, sorry, slide jump. Okay, this is, I think, this mismatch. So this is the scar which I was showing. Normally, we have to give the incision right from the, you're seeing the mosquito artery at the suprasternal notch. The incision extends from there till the lower bottom. But in this case, we have just done the lower half sternotomy, and we could manage to do the ASD closure. Now, this is the case too. You can see there's history of forehead sweating with suck rest, suck cycle, and fast breathing, but the saturations are 98%. Now, I'm leaving this cardiovascular examination or the auscultation on my cardiology colleague, but if we have this much symptoms, we know that there is some shunt lesion which is not turning the baby blue. So it fits into acyanotic congenital heart disease. And again, the diagnosis will be proved by the echocardiography. But if you see the clinical part, which is hinting towards a larger pressure shunt, so obviously it's not ASD, and the diagnosis was VSD, Let's say, for example, it was PDA also, which is a larger pressure shunt. So in VSD, we do the surgery between 3 to 6 months, unless it is associated with any other congenital heart disease like interruption of the arch or transposition of the great arteries, which requires surgery in the neonatal age. Then we do the VSD correction along with that correction. Otherwise, isolated VSD, we wait on anti-failure medications till 3 to 6 months of age. Again, if the VSD is divisible and the weight is around 8 kilos, we subject them for device if possible. Otherwise, they undergo for open heart surgery. Case 3 is, I think Dr. Supratim has already discussed, a baby who was discharged healthy and then readmitted on day 5 with poor feeding. And you can see that the lower limb pulses were feeble. So obviously the first diagnosis goes as the ductal might have shrunk. So the coact has manifested. But these can be the other differential diagnosis in such scenario. A baby with low cardiac output or septic shock also, you'll not have good peripheral pulses because of the peripheral shrinking. So the diagnosis is again confirmed by the, these are the other examples of systemic circulation drug dependent. But anyway, this kid was having coarctation. And coarctation, if there is severe left ventricular dysfunction or the kid is not clinically looking good to subject for cardiac correction, then we do catheter-based intervention in the cardiac lab, which is called as balloon angioplasty. Most often, we have to still take them back later on after 2-3 months once the kid has grown up, gained some weight for coact repair. Now, this is 48 hours newborn who has cyanosis at birth. The most common diagnosis again goes for transposition, great arteries. In transposition, what happens is, as shown in the picture, that the aorta is arising from the right ventricle. Normally, it arises from the left ventricle. So what happens is all the systemic venous blood, the deoxygenated blood, comes from the body and travels back to the body through the aorta because of the wrong connection. So these baby obviously cannot sustain the circulation and they have to undergo arterial switch, in which these transposed vessels have to be connected back to the correct ventricles. If there is a VSD along with the transposition, there is some mixing and these babies do have some better saturation as compared to without the VSD. Common cyanotic heart disease tetralogy of Fellow, again, any hardly cardiovascular markings. And in this, there is a hole between the two lower chambers. You can see there is a communication and the pulmonary artery is narrow. So the outflow from where the deoxygenated blood goes into the pulmonary artery is narrow. And that's why the shunting happens across the VSD, and that's why these patients are blue. This one. So if you have a tetralogy of Fellow, but with minimal cyanosis, and there are patients who have cyanotic spell, or few patients are having balanced circulation. So why I'm telling you all these three categories, because the treatment is decided based upon the symptoms of the patient. The spells which you might be encountering in your OPD practice, again, is agitation, irritability, not accepting the feeds, and profound cyanosis obviously lead to syncopal attack. So all these have to be treated. The basic is again volume resuscitation, oxygen, morphine if you have, beta blocker, otherwise refer to the tertiary care center. Now, surgical treatment initially was Leloctasic shunt, which was a palliative shunt to palliate the cyanosis. But nowadays we are moving towards the complete repair. But if somebody has to do the palliative shunt, two catheter-based interventions are PDA stent, Dr. Supratim has well mentioned, and the RVOT stent. Otherwise, what surgically we do are BT shunt or a Sano shunt. And in BT shunt, we connect artificial prosthetic tube graft from the innominate artery onto the ipsilateral pulmonary artery. Now, what it does, it just increases the pulmonary blood flow so that you have more blood going to the lungs and comes back oxygenated. So the baby's saturations are slightly better. We gain some weight, buy some more time, and then do the complete correction. But there are a couple of disadvantages of doing the shunt because the patient has to come back for second surgery. There are chances of shunt thrombosis, and the baby has to be on antiplatelet drug till the complete repair is being done. Similarly, shunt is a conduit placed between the right ventricle and the pulmonary artery for uniformity of the growth onto the both sides. The shunt was done onto the one side. Our hospital approach, we as an institutional approach, we try and prefer to do the complete repair at the time of diagnosis. Now, it depends if the anatomy is suitable for complete repair. Let's say the branch pulmonary artery, which is the most common determinant of the repair. If they are good size, we try and do the complete repair irrespective of age and weight. So we have done a couple of neonatal complete repairs also. And nowadays we routinely do about 3 months of age, we do the complete repair. But by and large, if a kid is minimally cyanosed, we can wait till 6 to 9 months for tetralogy of fellow before we do the complete intracardiac repair. If there is significant cyanosis and the anatomy is not suitable for complete repair, in those cases we stage them and we do a PDA stent or a BT shunt surgically. Now, this chart shows what all surgeries and what all follow-ups you have to tell to the patients who might be asking you. So if you go to the third table right from here, ASD, VSD, PD, and tetralogy, in which we have preserved the valve or the annulus, those are lifetime corrections. They do not need any medications or long-term follow-up. They can have any lifetime activity. There's no restriction for physical restriction or diet restriction. Now, the palliative surgeries like BT shunt or a PA band or atrial septectomy or any single ventricle surgeries, they do require lifelong follow-up or multiple stage surgeries at some point in time. Now, we come to the second paragraph, in which the AV canal or arterial switch and L kappa repair, they also need long-term follow-ups to see how the valves are functioning as the child is growing. So these are the things the parents, the common questions they might be asking in your OPD practice. This is a rare case in which we took the baby for tetralogy of fellow, but there was impending. You see, this is impending aorta, dilated and impending rupture, almost this white portion. And so in tetralogies, usually the aorta is dilated, but in this kid, there was aneurysmal dilation and it could rupture anytime. So we could not leave it just like that, just doing the tetralogy correction. So we had to replace this ascending aorta also along with the tetralogy correction in one go. This was a rare case, and that's why we are presenting here. So this is arrested heart and the sutures. You can see that this is the VSD patch. This is how the VSD is closed. And this is left ventricle. Right ventricle you cannot see. These are the coronary arteries. And the white one, what I'm holding, is the artificial tube which will be functioning as aorta, and the black one is the aortic valve. It's mechanical, artificial prosthesis, and the surgery is called as Bental. This baby, this is a lifetime process, but the baby has to take anticoagulation because of this mechanical prosthesis all along the life. This is the final picture after the repair. So another kid, we have done open heart surgeries, about 1.6 kgs. We have done arterial switch. The kid is now 5 years. And these are the procedures, just to name them. We have done all spectrum of cardiac surgery. And this is the age spectrum. Majority of, if you see that we are doing the infant and the neonatal work, 50% of our work is about less than 1 year. And similar is the weight. If you see that less than 5 kilo comprises of almost 36%, and less than 10 kilo is about 70% of our spectrum. Our ICU stay is about 1 to 4 days, and we have successfully sent about 98% patients back home after the surgery. So as everybody has mentioned, it's a team effort, and there's a team behind. This is our group founder chairman, Dr. Devi Shetty, and his slogan we still carry forward, that no child should be denied treatment. Now, we concluded here by saying that early identification of congenital heart disease, the corrective treatment is possible in more than 80%, and we have good results, and late presenters can lead to irreversible complication. And moreover, the prognosis of surgical management nowadays is good, and that's why they should be referred to a surgical center. Now, just for the visual delight, I have 2 short videos how we do the open heart surgery. So for doing any open heart surgery, we need cardiopulmonary bypass, and this is how the cardiopulmonary bypass or the heart-lung machine looks like. It's quite complicated. These are the roller pumps rolling around, some tubings, and these are going to the patient table. And we'll just take you along initial process of how we. So this is a schematic diagram of what heart-lung machine does. So all the blood from the heart, the systemic venous blood, which is entering into the heart, is diverted through the tubings into this heart-lung machine, which oxygenates and maintains the temperature and comes back and is given to the heart. Because for doing any heart surgery, we have to stop the heart. And now if the heart is pumping, we cannot just stop it, because the rest of the body is functioning, and the brain, kidney, liver all require the oxygenation and the blood supply. So all that is maintained by the heart-lung machine. And before we do that, before we stop the heart, we have to divert this function of the heart to the heart-lung machine, which is maintained by the perfusist. So this is how the patient is draped, and we are starting a heart surgery. So this is the patient is draped, and you are seeing in supine position. We give mid-sternal incision. So almost 99% surgeries are done by this approach. PDA ligation, coarctation, or a BT shunt are done by the thoracotomy approach. Now this is a saw which cuts the sternal bone. And this is the sternal spreader, which is spreaded, and now still we are dissecting the thymus and fat tissue over the pericardium. The pericardium still is closed. This is the electrocurrent buoy, which is helping us to achieve hemostasis, as well as now the pericardium is getting opened, and you'll start seeing how the heart looks like. It's unlike the 4-chamber what we draw and show them. Here the pericardial stays. We make a pericardial cradle, and this is the right angle is. This is the right atrium. You're seeing the gray color, and that's the aorta. Now you can see it very clearly. So this is before the cannulation, and now we'll cannulate so that we can pass on the blood to the heart-lung machine. Let me show you how we stop the heart. So this is the cannulation. We put various cannula. Now this the heart is stopped. You see, it's on a heart-lung machine, and the heart is stopped, not beating anymore. And we have opened the right atrium. Majority of the cardiac corrections are done by the right atrium through the right atrial approach. And all this blood is sucked out and given to the heart-lung machine, which filters out and gives it back. So all the patients who have to undergo heart surgery, open heart surgery, need blood transfusion. Any procedure we do when the heart is arrested, you can imagine that because of the cardiac ischemia, so we give some cardioplegic drugs to maintain the heart alive but sleeping for few minutes, and we have to do the cardiac correction within that much of time. So this is the cardioplegia delivery and showing the intracardiac anatomy. This is a transposition ventricle. This is the right ventricle, and the aorta is coming out from here. Normally the aorta should be coming out from the left ventricle. This is another small preterm 600-gram baby we did recently for PDL ligation. So the closed heart surgery we have done about 600 gram, but open heart surgery we have done 1.6 kilo for a complete repair. This is the aerial view of our hospital at Haji Ali Junction. Thank you very much. I think we'll take the questions at the end of the session, and I would like to invite Dr. Lopa now, who is our intensivist, and she will brief you about the intensive care approach for the cardiac corrections. Start.
Good afternoon, everyone. I'm Dr. Lopamudra. I'm the cardiac anesthesiologist. I do take care of OT as well as ICU. Today, I'm going to talk about ICU management for our cardiac patients, pediatric cardiac patients. Origin of the first dedicated pediatric intensive care units in 1950s, the field of pediatric intensive care has been expanding and sprouting new subspecialties. But the concept of dedicated pediatric cardiac intensive care units originated because of this unique requirements for management of children after cardiac surgery. In the early years of development of cardiac surgery, pediatric cardiac surgeons have been primarily responsible for this care. But since last 3 decades, other pediatric cardiac professionals like cardiologist, cardiac anesthesiologist, critical care nursing, respiratory therapists, and others have started to contribute increasingly to this care. So before discussing something else, we should know why there is need for this specific pediatric cardiac intensive care unit. With this facilities of accurate diagnosis and scope of complete correction, more and more children are undergoing surgical treatment. And so there is a lot of increasing the demand for this dedicated personnel for the specialized intensive care of these critically ill children. And it has been shown that dedicated team who are doing, they are providing much better outcomes in several centers. And nowadays, this trend is towards early primary surgical repair, like during early infancy and newborn period, which requires specially trained group of physicians, nurses, and supportive staffs who can handle this very young population. So our optimal post-op care in ICU, it requires accurate preoperative assessment, use of intraoperative findings and data, careful patient risk stratification, and meticulous anticipatory management. So, actual management, what are the bedside facilities you should have? Usually in any cardiac ICU, your patient area should be at least 150 to 200 square feet, which can accommodate a ventilator, like syringe pumps. Area should be there to accumulate syringe pumps, IV poles. And for neonates, we need bassinets with overhead radiant warmers. And for the kids, it will be a big bed. Monitoring equipment should be wall mounted to save physical space and to avoid overcrowding. And there should be electrical power from an uninterrupted source. Oxygen should be available, medical compressed air, vacuum outlets should be there in sufficient number. So, as intensivist, what should you know before your patient arrives in the ICU? You should have the knowledge of the pre-op conditions, which allows you to anticipate the post-op problems. Pre-op anatomy you should know. You should understand the pre-op physiology, like whether it is a left or right shunt, whether the patient is having pulmonary hypertension or any RVOT obstruction. If there is any non-cardiac problems like failure to thrive or any airway problems, whether patient is syndromic, having genetic problems, very much malnourished or having feeding intolerance, you should know about this. You should know about your past medical histories, patient's recent illness, or whether patient is on any medications. If patient has undergone any past surgeries and having any complications because of that, if patient has undergone any CAT or CT, you should know about that. Surgery, before patient comes to your ICU, you understood the physiology, but you should understand the effect of CPB. My colleague, Dr. Pradeep, explained you why CPB is needed, but it comes with a cost. So when we put patient on CPB, there is an abnormal circulatory environment. It doesn't provide you pulsatile arterial flow. It is always a non-pulsatile arterial flow. There is blood trauma, which gives rise to hemolysis. There are hemodilation, and there is exposure to the foreign surface. So it activates your inflammatory mediators and coagulation pathways, and it gives rise to stress response as well. Important part is there is systemic inflammatory response, and which activates and interacts many systems and cellular elements in the body. So it activates your complement systems, and it gives rise to your increase in the capillary permeability, and patient may develop interstitial edema later on. So once the patient comes to ICU, very important, it is very critical period when patient has been transferred from OT, and you need to be done, and you should get all those pertinent information. So what should you get? Should find out what surgery has been done and how much time has been passed after separation from CPB. You see what tube intubation, what ventilation strategy was going on, how much oxygenation was there, whether there was any arrhythmias, what sort of lines, tubes are there, patient is on what medication, what inotropic support, whether there is chance of any concerns for bleeding. And you should see how much, like what are the lab values and vitals are maintained during intra period, and what are the intra echo findings. This is our handover set, what we use in our ICU. It's in this paper we basically get all the information, and it helps us later on also. Once the patient reaches to you, you should have your ECG monitoring attached. This is the monitor, what we monitor in our ICU. You should have continuously observed all invasive pressure lines, and you should make it 0, and you should see that it is providing you accurate and normal waveforms. And ensure that all pressure transducers are continuously flushed, and all pressure lines are labeled appropriately. And if infants are less than 3 months, 6 months, then you should attach your central and peripheral temperature monitoring, because in cardiac ICU, this temperature control is very, very, very important. We try to keep the patients little bit hypothermic around 35 to 36, like that, so that it decreases your metabolic demand. And you should ensure your alarm limits what you want actually. It decreases your mental fatigue, and what alarm you are, so that your sisters, your nurses are acquainted with that, so that they can inform you on timely manner. And you should record your vital signs and invasive measures. First, initially hourly for first 4 hours, then hourly thereafter if the patient is stable. So in cardiac post-op ICU, low cardiac output syndrome is a common problem, usually reported around 25% of the patients, usually happens in first 6 to 12 hours after surgery. So what are the factors we believe to account for low cardiac output syndrome? Mainly if there is any hemodynamically significant residual lesion is there, and the myocardial dysfunction may probably result from prolonged periods of cardioplegia or myocardial ischemia and reperfusion injury. And post-op also perioperatively you can find out ventricular dysfunction. So what are the signs of reduced cardiac output? You can find there may be tachycardia, low blood pressure despite adequate CVP, poor urine output, and you may find cold peripheries with core to toe temperature gap of more than 3 degrees. Capillary refill time is more than 2 seconds. Spent peripheral percussion, reduced mixed venous oxygen saturations, increasing the trend in the lactate. And nowadays, if your institution is having nurse, that is also helpful to find out whether there is decrease in oxygen saturation. So it helps us to say that the patient is going into low cardiac output. But before treating, it is always, while you are managing, it is always better to do a prevention. So that's why it needs careful anticipation and aggressive cardiorespiratory treatment once patient is having low cardiac output. In post-op cardiac patients, you may find arrhythmias. They are very commonly found. Some children are at higher risk post-operatively, so you should get your 12-lead ECG immediately after surgery. And if patient has arrhythmias prior, you should get that thing. You can see all type of arrhythmias, but in cardiac ICUs, this junctional ectopic tachycardia is most common. It is usually a narrow complex tachycardia. It often starts as a nodal tachycardia and progress to AV dissociation with ventricular rate greater than 170 beats per minute. So first treatment is initiate simple cooling measures such as removing excess clothing and bedding. Inotropes should be reviewed to see that anything is precipitating that thing. Ensure your adequate analgesia and sedation. Check ABGs to see that all electrolytes are fine. If heart rate is less than 180 BP per minute, beats per minute, you can think of overdrive pacing to get back your normal rhythm. If still it is not affecting, so you can consider antiarrhythmic drug, and amiodarone is the drug of choice. So in cardiac ICU, you find most of the, many patients, particularly left to right shunts, they come with pulmonary hypertensions. So elevated PVR and resultant pulmonary hypertension is a common post-op complications. It can give rise to acutely elevated RV afterload, and which causes RV dysfunction and which can gives rise to cardiac arrest. So always initial approach to post-op pulmonary hypertension is prevention. Try to prevent increase in the pulmonary pressures. So try to avoid noxious stimuli as much as possible. Give additional sedation, analgesic, neuromuscular blockade. Adjust your ventilation so that you should avoid hypocarbia, avoid acidosis. If this is not affecting, then consider inhaled nitric oxide. Nowadays, medically, we can start using some sildenafil or bosentan as well. That thing. Most of the patients in cardiac ICU comes on ventilator. Very rarely a patient comes extubated, but you will find they are coming on ventilator. So you will find there is compromise on gas exchange that occurs because of endothelial dysfunction, left ventricular failure, pulmonary edema, shunt, inadequate left heart decompression, microatelectasis due to CPP, lung collapse, secretion, phrenic nerve injury, lot of in numbers. So you should adapt strategies where it should provide adequate gas exchange with minimizing the adverse effects on hemodynamics. So if you think of cardiac, who should be kept intubated, cardiac causes. So patients who have lung pump runs, having poor LV dysfunctions, if patients are hemodynamically unstable and having severe hypertension, usually we ventilate them electively. But some surgical patients who need early extubation, those are the patients who have passive pulmonary blood flows like Glenn and Fontaine. But before that, you should know what SAT's supposed to be. That means which patient need how much saturation. You should be well versed with that. So in our institution, we prefer early extubation. So what helps? Like by doing early extubations, we minimize the need for post-op sedations. We reduce the length of ICU admissions, reduce the incidence of nosocomial infections, and it improves the family and patient satisfactions. But in this, our physiotherapist plays a great role because these kids who are unable to take out those secretions, those who does lung collapse and all those things, our physiotherapist helps them to maintain their airway, maintain the lung mechanics. All the patients, cardiac patients, do come with drains. They may have either mediastinal or both mediastinal and pleural chest drains. And you should monitor drains initial period. Ideally, drain losses should be less than 2 ml per kg per hour in the first 4 hours. After that, it should be less than 1 ml per kg per hour subsequently. If it is more, you have to inform the surgeon to see whether is there any possibility of bleeding. And always we try to apply some suction, which is usually 2 kilopascal in its first day. And later on, we remove it. Coming to antibiotic prophylaxis, we do give prophylactic antibiotics according to the surgical antimicrobial prophylaxis guideline, which should be a broad spectrum antibiotic. Fever in the immediate post-op period, we usually we treat it very aggressively with antipyretic agents and cooling devices, so that it should not precipitate any arrhythmias, and it should, by cooling also, we reduce our oxygen consumption. If still fever persists after 48 hours, then we send blood cultures to identify if there is any specific organisms. Patients with history of previous hospitalization, neonates, malnourished patient having low cardiac output syndrome for more prolonged period, they are at more risk of infections. But always it is better is the preventive strategies to reduce this ICU infections by including strict adherence to the sterile technique, hand hygiene, and prompt removal of the lines, catheters, and tubes. We follow antibiotic stewardship program in our hospital to prevent antibiotic resistance. Even if patients are having sign and symptoms, we do send cultures and we upgrade our antibiotics. The moment we get that culture is negative and or patient is like sensitive to some low antibiotics, we do change them so that we try to prevent those antibiotic resistance. Nutrition plays an important role. Cardiac surgeries, patients particularly, they are prone for malnourishment. The pre-op conditions are like chronic heart failure, cardiac cachexia, less functional metabolic reserves, and they have coagulopathy. And after surgery, they may develop this endothelial dysfunctions of GI tract because of this CPB. So they are prone for malnourishment. If patient is malnourished, they provide worst post-op outcome in form of like worse functional recovery, higher rate of infections. There is increased rate of pneumonia, increased hospital stay, ICU stay, and decreased discharge to the home bed. And malnourished patients have more incidence of increased mortality and morbidity. So the moment patient comes to ICU, we prefer to start the enteral nutrition within 24 hours after surgery, if it is tolerating. According to the ASPEN and ASPEN guideline, we start with 25 to 30 kilocalorie and 1.5 to 2.5 gram of protein per day per kg body weight for critically ill patients. Despite all the things, despite good cardiac surgery, still we have certain cases where we face difficulties in the ICUs. Those are like all single ventricle patients, pre and post stage 1 repair, all patients with poor ventricular functions, all patients with pulmonary arterial PA bands and VT shunt, with severe pulmonary hypertension, patients on ECMO, and patients coming up with open chest. So last one, maybe ECMO. So low cardiac output syndrome, which is refractory to the medical therapy, their mechanical support should be considered. And it is life-saving for patients with refractory cardiac and respiratory failure. It also acts as a bridge to recovery for transplantation or any decision making. So summarizing my talk, pediatric cardiac ICU, it requires a comprehensive and multidisciplinary approach. You should have clear understanding of cardiovascular physiology, multi-organ system functions, and organ interactions in health as well as when patient is in disease. So you should focus on a preemptive approach in preventing deleterious effects associated with CPB and intraoperative events. If the patient is failing to progress along the projected course or patient is acutely decompensating, you should evaluate promptly with bedside assessment, lab evaluations, and echocardiography with that, and call all of your team members, think in one direction, and do for the best. Thank you. Yeah.
So we are just setting up for the panel discussion. In the meantime, if any of you have any questions, please put it in the chat box, or you can unmute yourself and ask.
Yeah.
So we heard talks from pediatric cardiologists and cardiac surgeons and intensivists and anesthetists. And we got to know all the small details about how usually a patient's pathway is once they are diagnosed to have a congenital heart disease, right? From the diagnosis, the investigations, management, interventions, and then how the post-op course is. But to go through a little bit of nuances, I would like the panel again to join in, and we'll have a little bit of panel discussion. Please feel free to ask questions or stop me wherever you want more detailed answers. So just to start, like we as pediatric cardiologists, we are doing so much of pediatric cardiac work, but in general practice, how is the burden of the disease? Is pediatric cardiac disease very, very common? So let us kind of get a little bit of glimpse of the burden of the problem and what kind of solutions are available presently in this country. I'd like Dr. Supratim to answer this question, please.
So, as we know, the general incidence of pediatric or congenital heart defects is 8 to 10 per 1,000 live births. And in India, looking at the birth rate, that translates to about 250,000 patients born every year with congenital heart defects. Now, 1/4 of these patients are estimated to require surgery or intervention within the first year of life, meaning they have a critical CHD. And of course, we have a huge backlog of patients from before. Now, pediatric cardiac services started in India in the late 90s. And since then, we have progressed by leaps and bounds. So today, we have many centers in most of the metropolitan cities and also in some of the second-tier cities. So a lot of good quality, high quality work is happening all over the country. But obviously, the number of trained specialists is much less than what is ideally required to take care of such a huge disease burden.
So the burden is huge, and as Dr. Sen said, that the cases keep piling up every year because we don't have enough centers or enough personnel to take care of this problem. Also, you know, as a disease, we are not on hyper alert to diagnose congenital heart disease. So a lot of times children come to the emergency room and then they're diagnosed as septicemia or something else. So I want to ask Dr. Kshitij, what are the silent markers alert and to diagnose a congenital heart disease, because certain critical cases may have a heart problem which is treatable, and that may be missed because we are not thinking about it. So as we say, what the mind knows only that the eyes can see. So what should our mind know? For all of the people who are listening, what would be the silent things that they should keep in mind?
To start off with, history and symptoms are very important. Any child in the first year of life comes with recurrent respiratory tract infection, failure to gain weight, having fast breathing continuously, and typical suck rest suck cycle, which we can elicit from history, excessive sweating on forehead. If any of those symptoms are present, then you should think in terms of heart disease. Also, sometimes the mild lowness in the syncope, and so these things are to be seen asked on history. Examination wise, we usually auscultate the heart directly. Nowadays, a lot of people, when the child comes to the OPD, is crying and don't have enough time to examine. One important thing is auscultation and palpation of pulses. You need to palpate the femoral pulse of the dorsal spleen. Make sure the child first and second heart from the moment. So basically, you have to look for signs of cardiac failure, any hepatomegaly is present, any tachycardia, tachycardia. So most of the time, you will have some symptom or sign, and you should have your eyes wide open to and try to investigate it with minimal of doubt. If you have, you should investigate it.
Sure. So we should have a high risk of suspicion, basically, is what he means to say. And it's back to the basics. Basically, just auscultating. Maybe a lot of us are very scared. We may not be able to auscultate well, or because the child is crying, we are not able to auscultate. So in those cases also, just basic things, just like full limb saturation, the blood pressure difference between the upper limb, lower limb, palpating pulses. All these things are quite crucial to diagnose anybody with congenital heart disease. I would like to ask Dr. Pradeep, so how far do we go as in terms of cardiac surgical correction of these cardiac illnesses? So how, from when did we start, like a little bit of historical aspects that we can give, and also if you can give us any insights about what you're looking ahead. So next 10 years, 20 years, where is this field going? Some insights on that as well, please.
So the cardiac surgery started in 1943 when first of all the PT Sheth was done. At that time, there was no heart-lung machine, so open heart surgery was not done. And so earlier surgeries were PT Sheth or PT dilation, and then 1956 to 60, the heart-lung machine was kind of invented. So we started doing the cardiac surgery. So we still say that cardiac surgery is still in infancy all around the world. But if you consider from 1960 to now, like it's almost 80-85 years, many surgeries have been done and many evolutions, and we have learned also that which surgeries last for how many years. So we are still evolving in the cardiac surgery and the techniques. And pediatric cardiac surgery, the future I would say is that maybe some addition of the robotics for the minimally invasive, but because everything is involved around the heart-lung machine, so it might take some time, and the babies have small chest. But this is what we are looking at. As far as the interventions are concerned, obviously the cardiologists are doing, like earlier what we were doing BT shunt, now they are doing the PA stents, RVOT stents to pediatric, all that in the neonatal age. So yeah, I would say that.
As rightly said, this is a very fast growing field. We are still in its infancy and we are growing very, very fast. Every new year we have some new therapies coming in, some new drugs coming in, new interventions coming in. We're all in the continuous cycle of learning, unlearning, and relearning. So in the coming future, we are very, very optimistic, like with regards to the life expectancy, with regards to the quality of life. We are very we are looking forward that these things will be normalized in patients with congenital heart disease. So coming to that point, I would like to ask Dr. Sen that currently what is the status? Once the child gets operated or gets an intervention or a device, so how is their life after that? And what kind of surgery do they require, repeat surgeries and interventions in the future? So can you just throw some light on that topic?
So most of the device closures and the transcatheter interventions are done in patients with two good-sized ventricles, and they have a normal life. So suppose you do VSD closure, ESD closure, PDA device closure, they will have a normal life. We do keep seeing them at least for 5 years post-procedure, just to see that there is no complication, but after that we will discharge them from follow-up. Same goes for the surgical patients who have had treatment of an acyanotic heart disease. They will have a normal life expectancy, normal exercise tolerance. They can have kids and all, no issues. Now coming to the cyanotic heart diseases, if you have complete repair, two ventricle repair, such as an arterial switch operation, most tetralogies, those are also generally single surgeries. The only caveat there is when you do a tetralogy repair, if the surgeons are not able to preserve the pulmonary valve, meaning you have a patient who does not have any obstruction in the pulmonary artery, but you have regurgitation, then a subset of these patients will, in the second decade of life, require a valve reimplantation. Now, that can be done either surgically, and nowadays, since the last 2 decades, we have now started doing transcatheter pulmonary valve implantation. So that's just one thing we tell the parents or the patients who have tetralogy or fellow, that if you require replacement, if you have a transannular patch, that valve will need replacement in the future. Now, there is also a subset of patients who have what is known as single ventricle circulation, which means that they don't have two good-sized ventricles, or their heart is formed in a way that we can't surgically separate it into a separate right and left pumping chamber. And these patients undergo a staged palliative procedure where we are trying to convert the heart to do the work only of the left-sided pumping chamber, the left ventricle. And we gradually take away the work of the right ventricle from the heart. So these patients who undergo the Glenn operation, the Pradhan operation, they don't have great long-term outcomes. We have seen that usually they are all right for the first 2 to 3 decades of life, but by the time they are about 20, 25 years of age, a lot of them will have heart failure. So that is, I would say, one of the limitations we have in the present day and age in terms of the spectrum we can treat. So I would say 80 to 85% of our patients, we are able to give them a normal lifespan. They have normal exercise tolerance and all, but this 15% is the single ventricle subset where they will have some activity restriction.
So, single ventricle people, as Dr. Sen said, that they might have heart failure after 20 to 25 years of age, or even later after 30 years, some people can have a whole life, and after that the ventricle starts failing. So what after that? So can Dr. Pradeep tell us what do we do after this set of patients have their heart started failing? Are there any options that we can give them to extend their life?
So once the heart starts failing, the option left is medical management. Once the medical management also gets exhausted, we have to consider or list the patient for heart transplantation. Heart transplantation needs quite a bit of workup. We have to see and take the biopsy of the heart, and once the patient is listed, there are certain categories in which the patient will be given the criteria before the patient or the recipient receives the heart. So more symptomatic or more sick or ailing heart will get the priority of that. And until then, we have to keep on medical management, or there are certain assist devices, but not many are available for the smaller side of the heart of the babies. Those are mainly meant for the adults. And that's why we do pediatric surgery or keep them on medical management until they attain 15 to 17 years at least age, so that we can get there is better chances of getting the adult heart. It's rare to get the neonatal or the pediatric age heart given in the Western world.
So that's cardiac transplantation is available for such kind of patients, though it is another disease. It's not like the end of the trouble. It's you have to be on monitoring, as Dr. Pradeep said, we need repeated biopsies, and that heart which is transplanted also has a limited lifespan. So it is not going to give you another 50 years of life, but maybe 10 to 20 years of life. So the condition or right now whatever present situation for a single ventricle disease is not as good as that for the patients with two ventricle disease. So how do we know that if we can prevent this, like Dr. Sen said, 8 to 10 of 1,000 childbirths are going to have a congenital heart problem naturally. So this is the natural incidence. So is there anything else that increases the risk of congenital heart disease, and are there any ways to prevent that risk? I would like Dr. Kshitij to answer that.
Some studies have shown folic acid supplementation before conception, before pregnancy, and continuing towards at least for the first trimester, helps in reducing the incidence of congenital heart disease. In addition, what we recommend now is getting a fetal echo done. Though it's not done in everyone, especially if the first child has had a heart disease or if the mother has had some heart disease, it is absolutely essential. I would generalize it to getting it done by every patient so that at least you pick them up critical congenital heart disease early, and we can avoid patients with single ventricle and complex heart where there are not many treatment options, great treatment options available. If you have, say, fetal echo has just a VSD, which has a completely correctable condition, it's fine. Those kids do well even after birth. But if you have a child with single ventricle, whom we know even after all the palliative surgery, not going to have a normal lifespan, it's better to pick them up early and give the family the option so that they can decide about the future.
Are there any infections or anything that the mother does it predispose her to have a child with
congenital
disease?
so torch infections in mother can lead to congenital heart disease. There are some medications that the mother takes which can cause congenital heart disease like antidepressant. So doctors have to be watchful to give these medications to the mothers so that you can avoid these conditions. And looking out for torch infection titers in the mother can predict about heart disease, but it's not a sure shot way of saying that the child will definitely have.
So as rightly said, most of the congenital heart disease idiopathic, there are very few etiologies which we can actually pinpoint, but very significant ones. So even like maternal alcohol consumption can increase the risk of congenital heart disease. Certain kind of syndromic associations, again, that can be picked with antenatal ultrasounds like Down syndrome. They have high incidence of congenital heart disease. But again, these are not we don't advise abortion to patients with simple heart problems. Only with complex heart problems, these we can give the choice for the termination of pregnancy. According to Dr. Lopa, as she mentioned, that good nutrition was quite predictable for good outcomes in the ICU. Is there anything else? Because when our doctors see patients with congenital heart disease, they are going to go for surgeries. Is there anything that they can do in the waiting period to make them better for the ICU care post-op? So, are there any measures that the doctors can take before the children go for surgeries to improve their outcomes?
If it is the infant patient,
Dr. Lopa is sitting farther away. So, please let us know if you can hear her well. Okay. Yeah, please.
The patient is admitted in the hospital, and there is a time we know that the patient is having like 7 to 8 days in between. Prior we can't, but in the hospital, yes, we can think of giving if patient is having some stress cycle and patient is not taking properly, we can put some NG feeds and increase the calorie intake in those patients, so that even if 100 or 200 grams increase in the nutrition also, it helps in our immunity. Later on, it helps in tolerating the feeds post-op also, and try to whoever sees the patients later on, even if we know that patient is now tolerating well the it can go for next 2-3 months. We can advise that with only breastfeeding it is not happening, and we should increase outside milk or outside the protein.
Human milk fortifiers
and high calorie diets you can think of, and it will increase the weight and which will help early recovery and early wound healing and preventing the infections.
So very rightly said, nutrition is the keystone. Also prevention of infections. So before they come to the hospital, if you see a child who's going to go for surgery, any surgery for that matter, especially for cardiac surgeries, most of these children with shunt disease will always have some kind of respiratory infection. They'll be coughing. So it's better to give antibiotics during that time. We always, as pediatricians, we want to be safe and we want to only give antibiotics to proven bacterial infections. But in this cases, I would like to urge all of you to keep a low threshold. So keep a low threshold for starting antibiotics with children with shunt lesions, because that is going to prevent respiratory infections. They are very susceptible to these respiratory infections, and which may actually decrease their general condition, and they may not, which will affect their ICU stay or the post-operative course. So,
just on this topic, suppose a patient with a PST has a pneumonia, how long would you wait before giving anesthetic clearance for that patient for the surgery?
So you have to actually check at whether it is like pneumonia is actually because of the bacterial thing, some infection related, or this is because of the cardiac issues. Sometimes we do take care, sometimes it is because of the cardiac thing. That's why that pneumonia is not getting cleared out. So you have to check that thing, you have to examine in that way. If it is the cardiac is the origin, then I will give clearance for that. But if you find no patient is febrile and having high count, CRP is high, and you find some pneumonia patch on the X-rays, then you think of some amount of infection is there, give some antibiotic, wait for 4 to 5 days and see that the symptoms are improving X-ray wise and clinically as well, then you can take the patient for surgery.
So basically, if someone has acute LRDA, we give antibiotic, the patient gets better, can be discharged, and if we give preferably 2 weeks of gap before we consider open heart surgery. What Dr. Lopa was mentioning, suppose the patient is already in hospital and worsening respiratory symptoms requiring ventilation, and we are failing to wean from the ventilator, then in those conditions we have to go in and correct the cardiac condition, because that's the primary nidus. Until unless we resort that out, probably antibiotics will not help, and the patient will always be stuck on ventilator and get further subsequent infections.
Yeah, so with regards to infection, prevention is always better than cure. So what about immunization? Should or is it contraindicated, or is it indicated to give immunization or specific immunization schedules for any cardiac patients?
We generally advise them to take all the vaccines available, including pneumococcal. In fact, patients who have asplenia, which is seen in some of these children with isomerism, the site is ambiguous subset of patients, they are more prone to infections with capsulated organisms. So, pneumococcal and pneumococcal vaccines become very important. Once a child has had cardiac surgery, we advise them not to be vaccinated for the next 1 month. And that is because if a patient is put on cardiopulmonary bypass, there are some studies which have shown that the immune response is a bit suboptimal. So if you give a vaccine in that 1 month, you might not have an adequate protection for that disease vaccinating against.
So we routinely see this, that in primary healthcare centers, when the child goes with congenital heart disease is not growing well, so they will see the growth and then they will say, okay, you have a heart problem, we are not immunizing you at this point in time. In fact, it should be counterproductive for the child, and we should in fact go and give the immunization, because that child needs that immunization more than the other healthy child because of the low immunity. So also I want to ask Dr. Kshitij, how about the post-operative care? So how long do the children need to be hospitalized, or when they go home, can they play normally? Or when do they start schooling? Both in case of device closures or surgical closures. So what kind of post-operative?
In case of transcatheter intervention, child goes home within a couple of days time, and then he can be back to normal. Only if you have put in an intracardiac device like an ASD or a BSD device, he needs to be on aspirin for 6 months. And we need to avoid MRI for 6 months. If the child has undergone a stenting procedure, even in those cases, we go aspirin. Other than that, there is no other restriction. We can do all the normal routine activity, go back to school. They need to avoid contact sports, because on aspirin they can get injured and life-threatening bleeds. So try to avoid contact sports. But normally normal sporting activity, routine schooling, everything they can continue. In case of surgical patient, care needs to be taken for the first month of post-operative. These kids will be on medication for the first 1 month of life after discharge. And post that, they can do all the routine stuff. For the similar here also, when they are on blood thinners like warfarin, we need to avoid contact food. Children who are on warfarin, they need to have special diet when they need to avoid leafy vegetables to reduce the action of warfarin. But most of them lead a normal life, normal going to school, going to work, all those things.
So what about the post-surgical patients? Like what kind of suture removal? When do they need to come back to hospital? How many times do they need to come back to the hospital after the surgery?
So once any patient is diagnosed with a congenital heart defect, we admit them and not take prior to surgery. And we do all the pre-surgery workup, which includes blood investigation, X-ray, ECG, if not done in the OPD. And if any additional imaging is required, like cardiac CT or cardiac catheterization, once everything is in place, we arrange the blood also. And then the pre-anesthesia checkup is done whether the baby is fit to undergo general anesthesia. After the surgery is done, which routinely takes about 4 to 6 hours for any open heart surgery, sometimes it's longer if it is a redo surgery or a second surgery, they take longer. And after the surgery, the babies are shifted into cardiac ICU, where as per their recovery, we keep them for 1 to 4 days. The smaller the kids, the infants and the neonates, or the less weight, they take longer time in ICU to come out of that. And after that, we shift the baby back to the ward with the mother. And another 3-4 days, we do a check, echo and X-ray. And then they go home. So this is about roughly 7 to 10 days of stay after the surgery. And we call them to the hospital after 1 month for the first follow-up echo. And that time we taper or stop the cardiac medication whatsoever are doing. We use all the absorbable sutures, so they don't need to cut except for 1 or 2 chest tube sutures, which can be cut at any peripheral center, or if the patient wish to come here, we do it here. It's just hardly a 1 minute job. And they can start taking shower with soap and water just after the suture removal, which is 15 days. No more dressing or betadine or any ointment application is required. Because we remove the suture, that means the wound is dry and it's as good as the neighboring skin, so we can just apply normal water.
So when do they start the schooling and other?
So we recommend that they can start the school or tuition, private tuitions, after 2 weeks. But if they have very active school life or they have to climb stairs and all, I would recommend anybody to go after 4 weeks. By the time the bone usually heals, the sternal bone what we cut, and then there are less chances of it going into Majhi. So that's the only recommendation. Otherwise, routine like how they were living before the surgery, there's not much of restriction.
Excellent. So that was quite good to hear that the recovery in children is fast, especially after sternotomy. They do much better than what adults do. So for adults, majority you have a restriction for many activities for 6 months. But as Dr. Pradeep said, the bone healing is much faster in children. So we don't usually ask them not to do certain things. If the baby is just a neonate or infant, so they are going to learn new motor skills every day. They are going to learn to sit, they are going to learn to stand, walk. So these things can happen normally and naturally even after a sternotomy. There is no restriction for these things. Another, like it's very one thing I would like to note here is that we have Olympic players who had a congenital heart disease, like ASD surgical closures done, and they have also played competitive sports at that level. So very good outcomes. Some certain kind of congenital heart disease lesions have excellent outcomes and very good recovery. I think from my side, I have tried to cover most of the points and try to give you a message regarding what work we do. If you have any other questions other than these, please feel free to ask. And any comments by the panelists?
So I have 2 comments about future directions of where our specialty will go. One is transcatheter valves. So the first percutaneous pulmonary valve was done in 2020. pulmonary even in India, but because of the cost, it is still done in very few patients. But as the costs come down and as hopefully insurance starts covering these complex procedures, more and more patients will be eligible to get these done. The second thing is VADs. So ventricular assist devices have become progressively more compact in the last 2 decades. And probably with newer technologies of miniaturization, maybe in the next decade, we will have VADs which are specifically suited for children. And some of these VADs might even be an alternative to a transplantation. So looking forward, maybe 20 years down the line, heart transplant will not be indicated in as many patients as it is indicated today. Maybe we can do a VAD and kind of let the child live normally with that device.
Also about my topic was advanced imaging technologies. So every radiation is a hazard. We are exposed to ionizing radiation even in the environment, but especially in hospital situations where we subject children to angiography or to CT scans, the ionizing radiation amount is quite high, and this we have seen a lot of studies showing that there is increased risk of cancers in this patient. So this newer advances, we can do lot of device closures through non-ionizing radiation techniques like the CMR or even ultrasound guided, or we can superimpose the CT scan imaging or other type of imaging in the cath lab machines, and then minimize the radiation exposure to the child. So that is as well as a very new thing, and it's growing very fast, and in future maybe we'll have radiation free or minimal radiation exposure for device closures. Another thing before we close for all the doctors is about behavioral aspect of children post congenital heart disease treatments. So actually, do you want to speak about it, Dr. Kshitij?
Some studies which have shown that post procedure, the child grows up, they may have some behavioral issue. There was a study from Boston which had looked into MRI of infants and undergone arteries with surgery, and those kids on follow-up were found to have behavioral issues. So these are things which we need to watch out for and see how they evolve. The multidisciplinary approach. So early pickup is essential. So we need to involve a developmental specialist whenever there is a iota of doubt that the child's behavior will be different. So just we have to keep an eye for it. It's not a very high association, but definitely we have seen it more than the normal population.
Exactly. So since we started treating these children and sending them home successfully, now we have more focus on the smaller aspects or the nuances of children with congenital heart disease. They are just like other children, but they may have certain problems which are different from the normal children after they undergo this treatment. Even exposure to pain in neonates and children to severe pain has shown to have a significant effect on their brain. So we have to be on high alert with regards to behaviours in these children, and they may need more of behavioral therapies or stuff like that in the life after the surgery. Anything else?
Any questions or will you take?
Yeah. So I'm just looking at the chat box. I don't see any questions. I think then I would like to conclude. Yeah, there's something here. So goodbye from the cardiac sciences team of SRCC. Thank you all of you for your patient listening and sparing a good bit of your afternoon with us today. Thank you everyone.
Thank you.